Oh, sorry, now that we're letting people in. Questions, will they get typed and I'll see them in chat, or people will ask? How are we going to do that?
We're going to ask people to put them in the chat, and
Okay.
then Joan is going to moderate for you.
Okay, perfect. I think you did that last time and it was really good, so that works.
Yeah, it worked out really well last time, so fingers crossed.
Yeah.
Good morning, everyone. We're just going to let people in and we'll be starting in a few minutes.
Good morning. Thank you.
If everyone can keep their microphone on mute, that would be great. And any questions along the way, please type into the chat. Okay, so we're going to get started. Welcome, everyone. My name is Dova Levin, and I am the Senior Director for Education and Program Management for the MGFA. Our volunteer this morning, who's worked very hard on this conference with me, is Joan Monroe, and she'll be doing some of the moderating later on. We'd like to thank our sponsors. We couldn't do this without them. Alexion, Argenix, Janssen, UCB, Immunovant, Horizon, Accredo, and Sanofi. We have a really great agenda today, and we're excited to have everyone at this conference. So I am going to turn this over to Joan, and she'll introduce our first speaker.
Thank you, Dova. Yes, we really do have a wonderful, fully packed program, so let's get started. Our first speaker is Dr. Todd Levine. Dr. Levine received his medical degree from Duke University in Durham, North Carolina. He completed a residency in neurology and a fellowship in neuromuscular disease at Washington University School of Medicine in St. Louis, Missouri. He has been a specialist in neuromuscular disorders for over 20 years. He's the director of the neurology department at Honor Health in Scottsdale, Arizona. Dr. Levine conducts extensive research in diseases of the nerves and muscles. He has published his findings in numerous peer-reviewed journals and lectures both nationally and internationally on these disorders. I'd also like to add that Dr. Levine has been my neurologist for over 5 years. Dr. Levine, thank you for all you do for all your patients. And now we'll turn the program over to you for information on the pros and cons of all the new MG medications. Dr. Levine.
All right, so let me put this on big screen. Okay, so thank you guys for joining me still, hopefully this morning, I think, for everybody in the Southwest at least. I was just doing another lecture in the East Coast where it's already the afternoon. Myasthenia has always been a disease that's very near and dear to my heart. In many ways, it's actually the reason I went into neurology. As a third-year medical student, I had a patient who had come in. She was about 7.5 months pregnant, had never been diagnosed with myasthenia. And over the 4 to 6 weeks before she came into the hospital, she had just gotten weaker and weaker. She literally was crawling on all fours because she couldn't walk anymore. Came in crisis, needed to be intubated. And over the next 4 weeks, we were able to get her stronger, deliver a healthy baby, and mom and baby went home. And in my naive conception of neurology, I thought that's really amazing. Neurology makes everybody better. And turns out that's not entirely true, but it is very much true for this disease. And so it's a disease, I think, that many of us that do neuromuscular work really like to treat. So I was going to start with a little bit of just kind of background stuff. So we have different types of muscles in our body. We have skeletal muscle, we have smooth muscle, and we have cardiac muscle. The skeletal muscle controls all of these features. So the way our eyes move, arms and legs move, breathing. It doesn't control digestion and the intestines, and it doesn't control the heart. Those are different types of muscle. But in myasthenia, any of those muscles, those skeletal muscles, can be affected and cause weakness. It's a very unpredictable disease, and it can often therefore be difficult to diagnose in the beginning because the symptoms can be variable. People can have, a good morning and a bad evening, and then the next day's good. And so it's not uncommon that it goes on for weeks or months, or in some cases even years before the disease is diagnosed. It also has these exacerbations. For many times, we don't know why. The disease just gets worse. And that's kind of the nature of autoimmune diseases, which is a variety of things can trigger them. Stress clearly is tied into the immune system. Concurrent infections, as your body tries to fight those infections, can rev up the immune system. Temperature, some medications, although my personal belief is that one's overstated, and then other kind of hormonal changes, not just thyroid hormones, but in particular in women, there can be changes with menstrual cycles and menopause and so forth. One of the things I'm going to try to get across through this talk is that this is a exciting time to be treating myasthenia, and a really anxiety-provoking and exciting time for patients with myasthenia, because when you have very few choices, there's not a lot of decision-making. But now we're entering an era where there are a lot of choices about how we're going to treat this disease. I think, as Dova mentioned, one of the people that's going to speak later today is going to talk about managing chronic diseases. And there's many, many important steps in managing chronic diseases. So just overall wellness, obviously monitoring the medications and the side effects of the medications. But one of the key things is really having a good relationship with the physician that you're working with. Somebody that you can tell when the symptoms are getting worse, someone that you feel listens to you. And so really trying to work on that relationship and finding a doctor that you can do that with is really critical. Okay, so this is a really remarkable graph and shows us over the last 100 years how this disease has changed. So the disease was named myasthenia gravis because there was a very high mortality rate. And so if you look at the black dots, that shows you the mortality rate at a given year. So in the early 1900s, the likelihood that a person would die from myasthenia was close to 100%, because we had no idea what to do with them and we had no tools available. It didn't really start to change until the 1920s. And what changed was the ability to ventilate somebody whose breathing muscles got so weak that they couldn't breathe on their own, because that's what everybody was dying from here, was really from respiratory problems. So we started to see a little bit of dip in the curve. The negative pressure ventilation, that's the iron lung, if you remember from polio days, but still zero medications that were known to do anything to affect the disease until the 1930s. And in the 1930s, two things happened. The first was the development of neostigmine, which is a precursor of mestinon or pyridostigmine. This was only given intravenously, but what it meant was when people went into the hospital, now they could give them medications that would make them stronger, and they had ventilation. And so patients began to recover from myasthenic crises, whereas before the mortality rate was greater than 80%. And then the first thymectomy was done in 1939. And you can see again, now we're really starting to cut into the mortality. So we can give patients neostigmine, we can rest them if their respiratory muscles are affected. And we began to start to think about the idea of thymectomies. And at that point, say by 1940, the mortality rate was down to 40%. So that's an amazing drop in the mortality rate. It dropped a little more with modern ventilation, so much better than the iron lung and the things that we had to do before that. But then the next big drop was right here in 1966. And in 1966 was when we realized that steroids could treat this disease. And when that happened, the mortality rate went from 30 to 40% down to about 10%. And then we began to use plasma exchange. And so you can see how saving lives in this disease really occurred long before 1975 with the invention of plasma exchange, at which point the mortality was about 10 or less percent, the chance of dying from this disease. Now, interestingly, that sort of correlates with the triangles, which is the prevalence of myasthenia. And it's probably not that the disease was actually more prevalent. It's probably back here in the 1900s and 1920s, everyone who had droopy eyes and mild to moderate weakness, but wasn't getting hospitalized, wasn't being diagnosed with this disease because we didn't have a test. And the first test occurred right in here when we began to have the ability to find the acetylcholine receptor antibodies. So you see, with better tests for diagnosing the disease, the prevalence has gone up. And even with the earliest of treatments, the mortality has come way down. And this is really with steroids and plasma exchange. But what this doesn't address is the blue box here. So now, beginning in the 1980s and 90s, we felt people shouldn't really die of myasthenia anymore. But people then began to say, okay, now we have to make people with myasthenia normal, or as close to normal as we can get. And so we began to shift towards not saving lives, but actually treating disability. Can we get people to do their normal things in a day? Can we get them to get back to work? Can women have babies? All of these issues. And that's really where the last 40 years has been focused on with this disease, is how do we manage disability? And this is going to be something that I really sort of want to emphasize, because disability comes from the disease, but disability also comes from our treatments. And so we as doctors have to be very careful. So we know that myasthenia is an autoimmune disease, which means that something is happening in the bone marrow to produce antibodies that shouldn't be made. So I sometimes will tell patients, I can easily eliminate your bone marrow, right? I could give enough chemotherapy medicine to wipe out your bone marrow, and you'll never make another antibody again, and that will cure your myasthenia. Of course, you're going to die from that treatment that I just gave you. So everything that we're doing now is really balancing treating the disease aggressively, fixing the disability as best we can, but understanding that this is a chronic disease. How do we manage a person for decades with this disease and not cause the harm that we could cause unless we're very careful? So this is the sort of therapeutic landscape for myasthenia. So what you see is in the 1930s, as I said, we had neostigmine, which is basically intravenous mestinon. 1939, we had thymectomy becoming a treatment. 1950s, we've got mechanical ventilation with the iron lung. And then the 1960s, corticosteroids and plasmapheresis. Then there was this period for, say, the next 50 years of trying to find better medications. And the reason we needed better medications, so why didn't we just stop in the 1960s? We didn't stop in the 1960s because plasmapheresis is not a very convenient treatment long-term, because it's basically like going on to dialysis. It's not that you can't do it, but we'd rather not have people have to go to the dialysis unit 2 or 3 times a week. Steroids are very effective for myasthenia, but we know that the long-term side effects of steroids are a real problem, and we'll talk about that. So now everybody, as I said, began to say, let's kind of think of ways that we can try to manage the disease with limiting the disability caused by our therapies. So one of the first was a drug called azathioprine, and then cyclosporin and cyclophosphamide. And these are referred to in a number of different ways. Sometimes people call these immune modulating therapies. Sometimes people call these steroid sparing agents, because they were drugs that we added to someone who was on steroids to try to allow us to reduce the amount of steroids. These medications were basically developed for organ transplant rejection. So someone sticks a kidney in me, my immune system is going to reject that kidney. So you give me poisons to weaken my immune system so I don't reject the kidney. In a person with myasthenia, their immune system is rejecting their muscle. So we said, let's steal all these drugs from the organ transplant people and see if we can use them. Now, we've used a lot of them. So azathioprine, cyclosporin, cyclophosphamide, mycophenolate or Cellcept, and tacrolimus are the big ones. They're pills, so they're convenient, and they don't have the steroids. They don't have the steroid side effects. The problem is, in all controlled trials, any randomized controlled trial looking at whether those drugs work, they don't work. None of them have ever worked in a controlled trial. Now, I use them, and I tend to believe that they do work in some people. but they also take a very long time to work. So these drugs were not able to be proven that they work, took a long time to work. And those drugs, even though they don't have the steroid side effects, they do have side effects of kidney, liver damage, weakening the immune system, more prone to infections. So they have gone through phases of being, in vogue, out of vogue. At the moment, they're a little bit out of vogue. But the important thing to know about those 5 drugs is they've never been proven to work. Now, in the middle of that came along IVIG. IVIG is an amazing drug. IVIG is antibodies from other people. Nobody knows how IVIG works. The way that I explain it to people is if you've got bad antibodies in your system and they're attacking your muscle, we flood your system with other people's antibodies and it blocks the bad antibodies. What we know about IVIG is that if it's going to work, it tends to work very quickly. It doesn't have any sustained benefit. So it's something that you really need to get every 3 to 4 weeks for most people, which is very inconvenient. And then it's also very, very expensive. So IVIG has been shown to work in myasthenia. It is a very widely accepted drug. And at the moment, any publication that talks about how we rank the therapies for myasthenia will say the following. There are 3 first-line therapies. First-line therapy number 1 is steroids. First-line therapy number 2 is IVIG. And first-line therapy number 3 is plasmapheresis. That's pretty much true across the world. The question is, what are second-line therapies versus third-line or fourth-line? And how do we rank those? And that's really where it gets much more complicated, and we don't know that yet. But that was the landscape then up until 2010 to 18, let's say. And what happened in 2010 and 18 were 2 important studies. One study, actually 3 important studies. 2 studies were done with rituximab. Rituximab is a medication that kills your B cells. And B cells are what make the antibodies. So it made a lot of sense to say, here's a disease that is caused by antibodies. Let's kill the B cells, leave the rest of the immune system okay, and see if we reduce the antibodies and make the patient better. When they did those trials in acetylcholine receptor positive myasthenia gravis patients, rituximab was not effective. Now, it still is used sometimes, 2nd, 3rd, 4th line, but the trial showed it wasn't effective. In patients with myasthenia caused by MuSK antibodies, rituximab was very effective and is now probably the first-line therapy for that subgroup, the MuSK patients. And then this drug called eculizumab or Soliris was approved, and we're going to talk a little bit more about that. So that's been out now for a couple of years. But what you see now is this explosion of drugs on the right side of this table. And this is the excitement about myasthenia right now, is that there are many, many drug companies who have now developed a number of different approaches, what we call targeted approaches, to really try to treat myasthenia, treat it in a way that's more convenient and with less side effects. And so if you look at these drugs, we're going to mainly focus on a couple of these. The first is the ravulizumab, which was approved in April of this year, or Ultomiris. The second is efgartigimod, which was approved at the end of last year. And then we'll just kind of mention some of these others. But to give you an idea, at the moment, the 2 that are FDA approved, the Ultomiris and the efgartigimod, these are still IV infusions. There are now companies like batoclimab, which is going to be like a little insulin injection of the same kinds of antibodies. So people are really starting to understand the science behind the disease, starting to understand that we want to make the treatment as safe and as convenient for people. And that's really the direction that we're sort of moving in. So I'm going to kind of focus, as I said, on a couple of these newer therapies on the right, and we'll go from there. Okay, so to understand the therapies, you first have to kind of understand the science behind the disease. So this is a nerve at the top of the picture here. This is the muscle at the bottom. The little acorn guys in red are the acetylcholine receptors. And then the little orange particles are the acetylcholine. So what has to happen is that the acetylcholine is released by the nerve. It moves over and then binds to the acetylcholine receptor, and that causes the muscle to move. That's how all of our muscles move. So now, if you have myasthenia, you've developed these antibodies. So these little Y-shaped guys are antibodies, and the antibodies are directed against the acetylcholine receptor. So what does that do? Well, the first is, if it just sits on top of the receptor, like over here on the right, then when the acetylcholine is released, it can't get to the acetylcholine receptor because it's blocked. It's unable for it to get there. The second way is this, which is called cross-linking. And so when you link these two antibodies together, it's going to cause the acetylcholine receptors to be taken back into the muscle. And then that's going to cause problems. And then the third way is that these antibodies serve to signal another group of proteins that are called complement. And so the little blue guy up there here is complement. And complement is designed to destroy whatever the antibody binds to. So the third thing that can happen is that the complement comes in and destroys these receptors and destroys the muscle membrane over here. So there are three different ways, and there may be more, but there are three that we know of. And one of the things that's important to understand is that what causes, we don't know if necessarily in one person, number one is the biggest factor or number three is the biggest factor. And that may have something to do with why patients respond differently to different medications, because they all may be slightly different in terms of what's happening to the patient. So what we've done in the past is basically to try to take what I sort of call the nuclear bomb approach, right? So to say, okay, we know the thymus is involved somehow. We know that the T cells cause the B cells to make the antibodies. So let's just attack all of that. And that's sort of what steroids do. And that's really kind of what the immunosuppressant medications do, is basically say, we're just going to poison the whole system and try to ramp it down, try to lower the level of activity in here. Now, IVIG, as I said, probably blocks these antibodies, although we don't really know. And plasmapheresis just sucks the bad antibodies out, which is great, and it works very quickly, but the body's still making more antibodies. So plasmapheresis doesn't really have any lasting effects either. We know that from online questionnaires that even patients that feel relatively okay with myasthenia often have a lot of symptoms. And so there's sort of, patients that are really bad with myasthenia, having a myasthenic crisis, people we know we have to treat very aggressively. But very often patients, because they've had this disease for so long, they don't even really know that they feel bad. They feel like that's as strong as I can be, or that's as much as I can do. And so we look for a level of treatment that we call minimal manifestations, which basically means, can we get people back to normal? And by normal, I mean pretty close to normal. And I think the goal these days should be, we can get you back to normal. And that's kind of what we want to try to achieve. So I mentioned corticosteroids. These are very effective, may in many ways be the most effective drug that we have for myasthenia. They're cheap. They've been around for a long time. You can get them anywhere worldwide. It's by far the most widely used medication. The problem is the side effects. So it causes bone loss, can cause muscle weakness, causes diabetes, causes increased risk of infection, hypertension. Lots of people, mood issues become a big problem on steroids. Weight gain is a big issue. Eye issues like cataracts can occur, and electrolyte imbalances. And so, again, steroids work, they're cheap, they work quickly, they're pills, fantastic, but this long list of side effects. And what I tell people about steroids is, it's not like other drugs where we say, oh, you might get this side effect, but don't worry about it. Basically, everybody gets steroid side effects. Doesn't mean you get all of them, but you're going to have some of them. And it's completely dependent on what dose of steroids you're on, for how long you're on them, and then just how your body tolerates them. If we look across the board at patients, about 80% of patients are on some type of immunosuppressive therapy. Again, about 90% of them have a response, meaning that they're better, but only about 2/3 are able to get to what I call minimal manifestations. So about 1/3 of all people still suffer as a result of this disease, despite being on the current therapies that we have. Now, if you were trying to design the ideal new treatment for myasthenia, you would say, I want it to work really fast. You would say it needs to work in people who've already failed their existing therapies. We want it to target the mechanisms that I just showed you, and we want it to have little in the way of side effects. So that's what you would want to design if you were sitting down at a drawing board. And that's really what the drug companies have been working on. So it basically boils down to 3 kinds of categories. I'm not going to focus too much on this one yet, what we call IL-6 inhibitors. There is some data coming out. The trial's still going on, so we don't know if it's going to work, but I'll show you a little bit about how this works. But I'm mainly going to focus on what we call the FcRn inhibitors and the complement inhibitors. So eculizumab, Soliris, ravulizumab, Ultomiris are complement inhibitors. Efgartigimod, rozimab, all the others are FcRn inhibitors. So let's talk about what those mechanisms are. Okay, so when I did med school, residency, fellowship, and about the first 20 years of my practice, I never heard of FcRn. So this is so new that it just wasn't even taught to us 20 years ago. But here's the idea. The idea is that as we sit here today, our blood is pumping through our body. In our blood is all the antibodies. So those antibodies are going through our bodies, circulating around, trying to figure out if there's something that they need to do. Now, if you think about the blood vessel is lined by cells. So imagine this is now a cell that's lining the blood vessel. And there's another cell here, and it creates like a tunnel. And then on the top, there's cells, right? So as these antibodies, these blue and red antibodies go around, as they go around the bloodstream, these cells soak them into something that's called an endosome. And in the endosome, they decide whether or not they are going to keep these antibodies and put them back into the bloodstream, or whether they're going to chew them up in something called a lysosome. So they come into the cell decides this is a good antibody, I'm going to keep it, and so it goes back to the endosome, goes back out to the bloodstream. Or it says, nope, not a good antibody, I want to kill it and put it into a lysosome, and then we're going to chew it up. Okay, crazy system that I just, again, never knew existed. Okay, so what is the signal for telling the antibody to go back out into the body or to get destroyed? Turns out the signal is the binding of FcRn, this little yellow piece here. So you can see when it comes in, the FcRn decides, do I like it? If I like it, it goes here, and then the antibody is released. If the FcRn doesn't bind, then it goes here into the lysosome and it gets destroyed. So when they realized this, they said, well, wait a minute. If we block FcRn and we don't allow FcRn to bind to the antibody, then the cell is just going to destroy most of the antibodies, right? So I was like, well, that's pretty clever. And that's exactly what this does. Now, it can't distinguish between the myasthenia antibody and the rest of your antibodies. So all of the antibody levels get lowered. It does seem like the autoantibodies, these red ones, get lowered a little more than the regular ones, but all the antibodies do get lowered. But the important point here is that we have other types of antibodies in our body. They're all not just IgG. We have IgM, IgA, and IgE. Those antibodies aren't touched by FcRn. So even if we lower the IgG, you have the other antibodies, and therefore the risk of infection is actually pretty darn low. So this was this concept, which was, again, just really earth-shattering. It's always interesting to me how this science kind of develops, and now you've got like 6 different pharma companies all developing similar molecules and how that happens at the same time. But it was very effective. And so in the MG trials that they did, it significantly reduced the level of the autoantibodies. So again, the IgG, these autoantibodies, all the antibodies are taken up by using the molecule that blocks FcRn. Most of the antibodies are going to get shuttled into here. Some will still get bound and go out, but you're destroying many more. As I said, you're not touching the other types of antibodies or the albumin. This is only true for IgG. And since the acetylcholine receptor antibodies are IgG antibodies, once they discovered this science, the first disease that they decided to test was myasthenia. Because myasthenia is, I tell people often, myasthenia is really about the only true autoimmune disease. And so people will say, well, lupus or rheumatoid arthritis or multiple sclerosis, those are all autoimmune diseases. And the answer is kind of. But in myasthenia, if I take the blood from a patient with myasthenia who has the antibodies and I give it to a normal person, that person has myasthenia for the next 4 to 6 weeks because those antibodies cause myasthenia. The second person isn't making the new antibodies, so they won't keep making them, but they will have the disease. That's why pregnant women who have babies, the babies can be born weak, kind of floppy, maybe not suck very well for the first couple of weeks because they're getting the antibodies from the mother. Now, if I do that in an MS patient, the baby's not born with MS. If I do that in a lupus patient, the baby's not born with lupus. So in those patients, we don't know that the antibody causes the disease. But in myasthenia, we know the antibody causes the disease. So the first disease they targeted with this amazing science was myasthenia. So again, they're trying to reduce the level of the antibodies. And they found a very significant percent of patients responded compared to placebo. Side effects, headache in some, a little bit of runny nose and nausea, but really very little in the way of significant side effects. So that's the FcRn approach, and it is a very effective approach to treat this disease. Now, the other mechanism I told you about was the complement-mediated mechanism, and the idea that the antibody binds to the receptor and then pulls in the complement. Now, the complement system is unbelievably complicated, and I don't know, other than maybe a few immunologists, any doctors, including myself, that could actually go through the entire complement, what we call complement cascade. It involves about 40 different proteins, but the idea is, remember I said when we were trying to treat myasthenia in an untargeted way, it was like the nuclear bomb approach, right? We would just wipe out the whole immune system, and we'd hope that we'd damage the bad part more than we damage the good part. These therapies are really like the smart bomb approach. So the smart bomb approach says, I don't need to wipe out your whole immune system. If complement is causing damage to the receptors and the muscle, let me just target the complement. And so again, very high level overview of this is when the complement is activated, it goes through a whole long pathway. And the key decision point in that pathway is what we call C5. And if C5 is cut in half to become C5a and C5b, then it's going to go and cause destruction. So again, in understanding this science, people said, well, what if we could stop C5 from getting cut in half? Would that prevent what we call the terminal complement complex or the membrane associated complex from causing the damage associated with this? So again, you've got all these complement things coming around. This is C3. It sticks to C5. That causes the cutting to C5a, which causes inflammation, and C5b, which actually literally punches holes in the muscle membrane, the membrane attack complex. It's just like punching a hole in the muscle and then trying to damage the muscle. So this process, the cleavage or the cutting of C5 is the key component to the complement cascade. And so to give you an idea, when you look at a normal neuromuscular junction, these gray lines all along here that look kind of like folds going up and down, that's the muscle membrane. So the muscle's below this. And these dark lines are the edge of the muscle, but see how it folds, folds, folds? The reason for those folds is that allows a lot of acetylcholine receptors. If you have a straight line, you can only get a few receptors. But if it folds like crazy, you can get receptors all up and down, all up and down. And that's the way a normal neuromuscular junction is supposed to look. In somebody with myasthenia, there's no folds. It's all just damaged. And therefore, there's no place for the acetylcholine receptors to get to. And this, we believe, is all mediated by the complement damage. So the question then was, could you stop C5 from getting cut? And that was the two drugs, Soliris and now Ultomiris. So these are C5 inhibitors. So it's an antibody, it sticks to C5, and it doesn't allow C5 to get cut in half. Therefore, C5 can't form those holes and can't cause the inflammation. Soliris was a very effective drug. It's been around for a few years now. Really well tolerated in most regards. The downside to Soliris was that it needed to be given every 2 weeks. And so just in the last, 6 months, they kind of reformatted it to form Ultomiris, which now is just one dose every 8 weeks. So very convenient dosing. And you can see here, the Ultomiris comes in, binds to C5, prevents C5 from getting cut, and therefore you don't have destruction at the neuromuscular junction. So again, both of these drugs just really amazing in terms of understanding the science of the disease, sitting down at a drawing board and then drawing up exactly what you'd want to target, and then taking it through the decade of research to prove that it really works. Side effects here were, again, headache, diarrhea, nausea, but all minimal. And we'll talk a little bit about this issue. So complement is also important in a number of other things in our immune system. We have it not just for myasthenia, and one of which is helping fight certain types of infections. And one of those types of infections is a meningococcal infection. And you may sometimes see ads on the news for like young kids in college or the military needing to get their meningococcal vaccinations. So in anyone who receives complement inhibitors, we need to give them vaccines for the meningococcal infections. So what that means then is you need to get 2 vaccines, this one, Men A and Men B, 2 weeks before you start onto the Ultomiris, and then booster doses, and then booster doses after that. So these days we all live by vaccines. But in people that get the vaccines, the chance of getting the meningococcal infections is massively reduced. And again, it's not really an infection that most of us are exposed to. I've never been vaccinated for it. I wouldn't encounter somebody with it, but it's really just to have to be on the safer side to get those vaccinations. Now, everything I just told you is really about acetylcholine receptor antibody positive people. Okay, so that's 85% of the people with myasthenia gravis. We know that people have other antibodies. So the second most common, as I mentioned, are MuSK antibodies. There's one called LRP4, there's one called agrin. And then even with all of the antibodies, there's still about 5% of the people that are antibody negative, meaning we just don't find the antibodies, but they still look, behave, and respond just like people with myasthenia gravis do. That group at the moment is a challenge because these drugs were only tested in the acetylcholine receptor positive people. So therefore, if I want to prescribe it for a MuSK patient, or I want to prescribe it for an antibody negative patient, it is very difficult. It's not impossible. It does require me speaking to the medical director, explaining we've tried more than 1 or 2 previous therapies and that the disease is significant. And so I have been successful on 1 or 2 occasions to get that, but it is much more difficult. And the same is true for any of the antibodies or what we call the seronegative patients. So what all this means then, as I said in the beginning, is that we have a lot of choices, which is fantastic. And it means we really, as doctors and patients, have to have a conversation about what is important to somebody in terms of their therapies. Some patients prefer steroids because it's a pill, it's cheap, they don't have to worry about anything, and they're going to do the monitoring that they need to do. Some patients have lots of comorbidities like diabetes or obesity or osteoporosis, where steroids would be a terrible choice. Some younger patients, younger women, we end up in very long conversations about family planning and when do they want to have children and what medications could we keep them on during that period of time and what can't we do. So, and all those things change. I mean, one of the things I like about treating MG patients, as I said, is I've had patients now for 30 years. So I get to see them through all the different stages of their life. And what's important to them at 40 is different than what's important to them at 70. But the goals should still be, and more now, really more than ever, getting to minimal manifestations where it just doesn't feel like the disease is impacting your daily life, and doing that with as little impact in terms of your day-to-day life and as little side effects. So that's really kind of our goal. So just to talk a little bit about we talked about that ideal drug and how fast they work. So prednisone certainly can work within weeks. As I mentioned before, azathioprine, very long, Cellcept, very long, cyclosporin and tacrolimus, really probably 6 months. So these are drugs that take a long time to work. The two newer drugs, the efgartigimod and ravulizumab or Soliris, really work within 1 to 2 weeks. So it's really rapid response with these therapies, which is amazing. I just want to talk a little bit about dosing of the FcRn molecule, efgartigimod. So again, we have to think about not only side effects, but how the dosing of this works. What we do here is we do 4 weekly doses, so once a week for 4 weeks. If you're going to get better, you're better by then. And then we see how long the improvement lasts. Now, in some people, it's been 2 or 3 weeks, and some people it's been 2 or 3 months. If we can go 2 or 3 months and then do another 4 cycles, that's not so bad. If we go 2 or 3 weeks and then have to do 4 more doses, that's starting to become less convenient. And I think we're sort of learning this. The drug company, in fact, is now doing a trial to look at just every other weekly dosing. Again, thinking about how we dose these medications and the impact it has on your daily life. So I think I really kind of talked about this already. Again, it's individualized treatment. We now have so many therapies that we didn't have 20 years ago. What you prefer as the patient, how you respond, what other medications you're on, and then just how it impacts your daily life. So again, the great news is there's more medications now. There's going to be 4 to 6 new medications in the next 2 years. For the MuSK LRP4 and seronegative patients, we're still waiting trials to prove efficacy. I think they will clearly work. The biggest issue is unless you have the trials, the insurance companies can just say no. And then again, really just trying to emphasize the communication to identify the best treatment for you. And best doesn't necessarily have to mean most effective. Best means gives you your life back, which is really what we're shooting for. So I can stop there, Joan, and take any questions.
Sorry, I have my mic off. Wow, thank you. That was amazing information. And you answered a lot of questions during the talk, but we still have a ton more. So I'll start with a few, and then Dova will probably jump in and shut us off when it's time. We have one question that a lot of people are wondering about. If you are getting IVIG, and now that so many people have had COVID, if those people that have had COVID are donating plasma, will we as IVIG recipients receive COVID antibodies?
Yes, so that's been measured starting about, beginning of 21, so about 12 months into the pandemic. And the COVID antibodies are definitely in the IVIG. We don't know exactly how much protection that gives you. We still recommend vaccines, but probably for people that are getting IVIG, they are a little extra protected from COVID with or without the vaccines. Yeah.
Great, thank you. One thing that you brought up that I think was really important was to have a good relationship with your doctor. I really appreciated you bringing that up because there are so many patients that don't have a good relationship and they're not getting the right treatment. So I just wanted to say thank you for that. I'll get to a couple of questions now that are online here. We've got one from Frank. Does Vyvgart therapy mean to replace immunomodulating drugs like methotrexate, or are they used in conjunction together?
So it hasn't been studied, and in the trials, I don't think people were able to be on the other oral immunosuppressive therapies. So I don't think we know directly. But in my mind, if I'm starting Vyvgart or Ultomiris, my hope is to get you off of everything else. I think those are both incredibly effective drugs. I mean, again, nothing works for everyone, but those are very effective drugs. And anytime we add a new therapy, if we see it work, the next question is, can I get rid of some of the old therapies? Because again, we're treating you for, I'm not sure how old you are, but for many of these people, I've got 20 and 30-year-olds with myasthenia. I got to treat them for 50, 60 years. So the less long-term toxicity we can give to people, the better. So so my goal very often is use the newer agents to get off the steroids, and then if you're still doing well, get off the oral immunosuppressive therapy and so forth.
Okay, great, thank you. Here's an interesting question from Janie. What treatment is used for seronegative ocular MG?
Yeah, it's a good question. There's two answers to that. So there are some people with ocular MG that really have fairly minimal symptoms and will just take Mestinon. So one option, if it's not bad ocular MG, is Mestinon alone. I also think as doctors, we sometimes minimize how bad just ocular MG is. So for example, in all of these trials, ocular was excluded because basically the drug company said, well, that's too mild. We don't need to do that. Well, I've got a truck driver who has ocular MG, and if his MG is bad, he can't drive a truck, and that's his job. So like, that's bad, right?
Yeah.
Then you have to treat more aggressively. So I think, most of us would probably try to see if a low dose of prednisone could work. If it were really bad, something like IVIG could be used in ocular myasthenia. So basically all the same therapies could be. It just depends on the severity of the eye symptoms. So,
okay, thank you. Here's one from Nick. What might cause Soliris treatment to fail or partially fail for symptoms to recur during the treatment?
Well, so, as I went through the different mechanisms, and I said, we don't know which mechanism is going to be the most significant for any given patient. So even though Soliris and Ultomiris are great medications and they block complement, and we think that that's really effective, if your particular antibody is causing the disease not predominantly through complement, then those medications won't work. And the challenge in autoimmune diseases is that, even though I showed you those 3 pathways, I'm sure there's 10 more that we don't know about. And in a given person, that could change even from year to year or decade to decade. So I've seen people, for example, with Soliris who do great for the first couple of years, and then it seems to kind of be wearing off a little bit. And in my head, without any proof of this, I kind of feel like, well, okay, now their immune system found another way to go about this because you block the complement. The immune system does that. The immune system, we've known that for a very long time. If you block something about the immune system will try to find a path around that. And so it may be that some of these medications work for a while until a person's immune system then finds a way around that, which I think we'll learn more about that with time.
Well, that's interesting, kind of scary that our immune system can do that, but thank you for letting us know. Here's another question from Julia. What is your experience with patients who have moved from Soliris to Ultomiris?
So the mechanism is pretty much the same. And so I think I've probably moved 20 or 30 at this point, and all have done well. I can't think of one who hasn't. So I think if it were me as the patient and I had done well on Solaris, moving to Ultomeris so that I could get an injection every 8 weeks as opposed to every 2 weeks is kind of a no-brainer. And side effect and efficacy wise, I think it's the same.
Okay, thank you. Here's another one from Ginny. If someone is stable on some of the old therapies, such as Cellcept, would you them to the newer drugs?
Yeah, so it's a good question. So the challenges are, what about the long-term side effects of Cellcept? So again, if it was a young person, I think it's a really important conversation to have, which is we see more skin cancers in people on Cellcept after 10, 20 years. We do see some effect on the bone marrow and those kinds of things. So the reason you would change if you're well controlled on Cellcept would really just be the long-term side effects. Now, if somebody were older, where 20 years, maybe a long time, then it may not be as much of an issue. But that would be sort of the main incentive to change.
That makes sense. Thank you. Here's a question. So how does a neurologist decide what treatment is best for a particular patient?
Well, so it's so we have a lot of options, and it really depends also kind of on the state. It's a hard question, the stage of the disease and the severity of the disease. But the overarching idea is to really kind of understand that patient and then figure out what the side effects of the medicines are going to be. So if you think about IVIG, prednisone, Vyvgart, Solaris, Ultomeris, these are now very effective therapies. Now, nothing's going to work in everyone, but if you just take a ballpark number, I'd say 80 to 90% of the people that you put on those drugs will get better. Okay. So you can't really make a decision based on which is going to be better. You have to make a decision based on the potential side effects and how it fits into that patient. So if they're diabetic, I'm not going to really want to do steroids. If they have, IV access problems, maybe 4 infusions a week, or IVIG is not a great option, and once every 8 weeks becomes a better option. So it's really trying to manage all of those things. And I think in a lot of ways, it's one of the advantages if you can see a neurologist who does a lot of MG, well, whatever your disease is, if you can see a doctor who does a lot of it, they're going to understand the nuances a little bit better than just picking one of those 5. Now, picking one of those 5 will work. So it doesn't matter. Pick one of those 5, you'll probably get better. But there are subtleties that become important, and then particularly as the disease progresses and you're followed for longer and longer, knowing what you can switch to, not switch to, those kinds of things. So that's the art of medicine. There's not really a great answer to that, but I think that I feel strongly that the patient has to have a really big voice in that.
Thank you. Yeah, that makes definite sense. Here's another one. So how about seronegative patients? There are so many, as you said in your talk, there are so many things that seronegative people weren't even involved in the trials. So how do you go about helping them?
Well, so we have to use the same kinds of medicines. So the first is to really be sure that it is seronegative myasthenia. So there are many other diseases, muscle diseases, nerve diseases that can kind of look that way. So when you don't have the sort of gold standard test, right? So if you have acetylcholine receptor antibodies, you have myasthenia. It's one of the few hard and fast rules in medicine. Once you get to seronegative, now we don't necessarily have that hard and fast rule. So the first thing is to be really certain that that's what this is. If we're really certain that that's what this is, so based on nerve conduction studies or other things, then we use all the same medicines because we believe that the antibodies are there. So, 20 years ago, we didn't know about MuSK or LRP4. And so all those people were called seronegative, even though we now know they have antibodies. I think most of us believe that that's true for the seronegative patients as well. We just haven't discovered the antibodies yet. It's not that they're not there.
Mhm.
So therefore, we use the same therapies. The challenge is, what do the insurance companies let us use? And for now, Vyvgart, Soliris, and Ultomiris are not easy to get covered in seronegative.
Okay, thank you. Let's see. I think we have time for one more question here. Can you stay on a low dose of prednisone under 10 milligrams for many years without a lot of damage? This would be in conjunction with other drugs. So difficult to wean off those last 10 milligrams.
So the side effects, as I said, they're really dependent on the dose, how long you're on it, and you as a person. Okay. And everybody's different. So I certainly have some people that stay on 5 or 10 milligrams, and that's it. I mean, their MG is great on 5 or 10 milligrams, and they'd rather stay on that than switch to anything else. And you don't know if the other drugs are going to work and so forth. So as I said, prednisone is a great drug. The question of side effects is, you just have to be careful. So, watching the sugar, doing bone density tests to look for osteoporosis, to look for cataracts, all those kinds of things. But I've even had patients that had cataracts on prednisone, and they said, I had cataract surgery, no big deal, and I'll stay on the prednisone. So again, it's that conversation. So the answer is yes, you can stay on low dose prednisone and not have bad side effects, but you just have to be careful. And even on low dose, some people will have bad side effects.
Oh, thank you. Dova, there's just one more, so let's see if we can get that in. Is thymectomy recommended for any LRP4, oh gosh, another one came in, plus GMG non-thymoma patient in their mid-30s to reduce potential adverse effects of being on long-term immunosuppressants?
So we don't know the answer to that, again, because it hasn't been studied, because the LRP4 population is so low. In the acetylcholine receptor antibody positive people, we do think young people should have a thymectomy, even if they don't have a thymoma. And that was published in the New England Journal. And the reason is because over the long run, meaning decades, the people who have thymectomies need less medication. In fact, I'm doing it on a patient just next week who's MuSK positive, even though there's no data that you necessarily should do that. But, she's very difficult to control, and therefore anything we can do to help, I think, is beneficial. And I'd say the same is probably true for LRP4. So I'd say if you're moderately affected and young with any of the antibodies, thymectomy probably makes sense.
Okay, great. Well, we do have to end it now. If there are any other questions that pop up, perhaps if it's okay with you, we could email them to you and then we can post the answers.
There is one more that we'll ask, Joan.
Sure.
The one more that I'm going to ask is, am I able to receive the second COVID booster while still on mycophenolate and prednisone?
So the answer is yes. Anything that suppresses your immune system will mean that you may not respond to the booster as well. There's no harm in getting it, but we can't be sure that you're going to respond as well. But at the same time, if you have MG and you're on those medications and get COVID, that is a really bad combination of things. So we do recommend that everybody gets now the fourth, all four. Yeah.
Okay, thank you. We really appreciated your time, Dr. Levine. I mean, you had another talk earlier this morning and now us. So we hope you enjoy the rest of your weekend.
All right. Thank you. Thank you all.
Thank you.
Thank you so much.
Bye.
Okay. So our next speaker, I'm going to introduce our next speaker. Dr. Emmanuel Tiangsun is a pediatric neurologist. Dr. Tiangsun, hold on one second, I'm blocking my own view. Dr. Tiangsun is part of the Division of Neurology at Children's Hospital, Los Angeles, as a specialist in the treatment of pediatric neuromuscular disorders. She is currently the Associate Program Director of the Child Neurology Residency Program at Children's Hospital, Los Angeles, and previously headed education and didactic programs within the residency. Dr. Tiangsun received her medical degree from the St. Louis University School of Medicine and completed her pediatric and neurology training at Children's Hospital Los Angeles. Served as a fellow in neuromuscular medicine at the University of California, Los Angeles. Dr. Chiang-Sun specializes in the treatment and diagnosis of disorders in the pediatric population. I am going to stop sharing, and I'm going to allow Dr. Chiang-Sun to go ahead and share her screen. I think
Are
you're
you
on
able to
mute.
see, are you able to see the PowerPoint presentation?
Yes.
Okay, great.
If you
So,
can put it in, yep, perfect.
yeah, you got it. Okay.
Yep.
Thank you, Dova, for that lovely introduction. As she said, I'm Dr. Tiongson. I work at Children's Hospital Los Angeles, CHLA, and thank you so much for inviting me today. I was invited to give a talk about how myasthenia is different in the pediatric population, and there are some significant differences. And just like Dr. Levine closed out with, it's important to go to a doctor, whichever disease that you have, that is experienced and has a lot of experience in a particular field. So for me, my passion, and actually people that I like to see, are children with myasthenia gravis, or consultation for. So we'll go through what is so different about it. So here's an outline of what we'll be going through today, what myasthenia gravis can look like in kids, how do we diagnose it, and then treatments available for kids with myasthenia, and then differences between treating adults and kids, the prognosis for kids with myasthenia, and then follow-up for children with myasthenia gravis. So interestingly, myasthenia has what we call a bimodal distribution. The onset is usually in older individuals or younger individuals under 30. And so the graph usually presented in papers is like this, where you'll have age of onset kind of in the younger ages. Females predominate in the younger ages, and then in the older ages, you kind of have males kind of taking over. But in the middle, you don't really see as many. So when people ask me, is pediatric myasthenia really that rare? It's actually like within the range of the age of onset. And so this is true in most of pediatric neurology, but we take a really good family history to see what's going on. So there are a lot of autoimmune factors that can make it more likely for family members or children in a family to have myasthenia gravis. So for example, I've uncovered in several families, high or low thyroid disease. That's an autoimmune condition like Hashimoto thyroiditis. One of the relatives who developed rheumatoid arthritis later in life, and they are treated with steroids or methotrexate. Systemic lupus, and then in young age, even diabetes type 1, which is autoimmune, can predispose you to get a second autoimmune disease, such as myasthenia gravis. I actually have a patient like this right now, and we diagnosed it based on this history. And so how do these children usually present to us? This may come up as a visit to the eye doctor. And so the eye doctor looks at it and says, oh, your eyelid is droopy on one side. Or the parents notice that the eyes are quite not aligned, or there's the droop with a misalignment of the eye. If it's in the body, it's like, wow, like she's great in the morning, but really tired by the evening or afternoon. But then she takes a nap and she wakes up and her face is great. And then sometimes the patients are like, why am I here? The eye doctor sent me here, and they have to just inform them what I see. And then specifically, there are some doctors in the community that are quite familiar with myasthenia. And so they send specially to our center because they know they'll get good treatment for myasthenia. So presenting signs in myasthenia, usually in the kids, it does start with a subtle eyelid droop, and it may just be on one side. And then they'll say, oh yeah, maybe that was just, a transient thing, because it goes away after rest. But then it could progress on that one side, and then it could progress to the other side. But here, this picture is just showing she does have a ptosis or eyelid droop on that left side. And then after she takes a rest in B, she opens it up, it's better. And then D through F is just showing the ice pack test, where it gets a little bit better after you give an ice pack to it. There's some really cool science behind why the ice pack works, but this is historically the case. People with myasthenia do better in the cold than they do in the hot. And so the first presentation can often be ocular. It could also go completely to the other side, which is a pediatric patient can present the first time in a myasthenic crisis. And this has happened before, where the patient presents and unexplained, just can't breathe, can't swallow. There's a lot of drooling, the whole body's weak. And so the first time I met some of my patients, they were intubated in the ICU. And so here are just like progression that I kind of alluded to earlier. If it starts with ptosis or eyelid droop on one side, it can eventually evolve the other eye. If there's just ptosis, you could eventually have eye movement abnormalities because those small eye muscles do tend to fatigue fast as well. If it started with the eyes, it can eventually involve the body, and this is called generalization of symptoms. And then if it involves the eyes, you could also see symptoms spread to other parts of the face and throat. And so we, as myasthenia doctors, always pay attention to the voice quality. If it changes by nighttime, your swallowing and chewing, if that changes by the end of the day, the same thing with breathing. And so how do we make this diagnosis? A lot of pediatric neurology in general is an observational exam because it's very difficult sometimes to ask a young child to cooperate with you. But there is a way to test for fatigability. In addition, we look for confirmation in blood work to look for the antibodies. And as Dr. Levine mentioned, we not only have acetylcholine receptor antibodies to look for, we have other types to look for now as well. If they're all negative, such as a seronegative myasthenia, but we think the clinical really fits with it, we can do something called a repetitive nerve stimulation, or RNS. This is a nerve conduction study that's done by neuromuscular doctors. And so this is my favorite part of the talks that I give about pediatric myasthenia. It's like, how do you examine a child? So really, you just walk in the room and start watching them. And so you can just watch them from the corner of your eye while you're getting the story from the parents. And this is usually a very accurate exam because they'll be climbing up and down on mom and dad, climbing up on the furniture, getting on the floor and getting up, playing with toys. So it's very informative. And then when I get to an eye exam, I can't just ask the child to look up, left, right, and down. I'll actually take it's usually a screen, take their screen and use it in all the directions. And sometimes I could actually put it up there for 40 seconds or so with sustained up gaze if it's a show they particularly like. So for example, I think the hot thing for the little kids right now is Coco Melon. So they'll go ahead and watch that for a good 40 seconds. And then for arm examination, I could see, are they proximally weak? If they're weak and tiring in the shoulders, I could see that. If they're able to lift their hands over the head, that's a good sign. And then if I can't get it sustained, we'll do a lot of high fives. And then leg examination, we'll see what they're doing in the room, and also we'll try to test it. And so I'll see how well they can do jumping, climbing. We used to have a room with stairs in it. They'd go up and down the stairs even without my prompting. And then in older children and then in the adult range, we can do reliable fatigable muscle testing. So every time one of my patients comes to see me, they know they're going to do at least 10 arm thrusts and 10 deep squats together with me, and then testing their strength before and after. And then we can also do the testing for double vision as well as eyelid droop. But really, like in combination to what I see in the clinic, depending if I'm seeing you in the morning, whether or not you took your medication, it's really the report of how you're doing throughout the day. Like, how is your fatigue? How is your perception of symptoms? So that in combination with a good exam. And so this is a list of tests that doctors often send for myasthenia, also for monitoring of medications while you're on them, since it does involve immune system. So we'd often send a complete blood count. Prednisone can make your white blood cells on the lower side, and then as well as other immune therapies. We'll get a metabolic panel to check out the liver particularly. So that's the AST and ALT. And then there are acetylcholine receptor antibodies. If you really want to get the biggest bang for your buck in terms of lab testing, all you need really is the acetylcholine receptor binding antibody, since it's the most specific one. Though it's common to send all three, which I often do because our hospital is able to do it. So we'll often send the binding, modulating, and blocking antibodies together. If those are negative, then we move to other antibodies or test them all at the same time if we have a suspicion. So for example, MuSK antibody or muscle-specific kinase antibody, it's really strikingly in the face and not really affecting the body as much. So if we really suspect it, we'll send that right away. And then the treatment is different for MuSK myasthenia, so it's important to know what antibody your patient has. And so I did talk about repetitive nerve stimulation. So if all that testing is negative, you may be referred for nerve testing with nerve conduction studies. The specific test for myasthenia is repetitive nerve stimulation. So the doctor who refers has to be very specific. That's what they're looking for. Otherwise, we'll miss doing the special test. And so it's exactly how it sounds. It's repetitive nerve stimulation, so little static shocks. It's kind of like an electrical fatiguing of the muscle, which is helpful because then you can visualize that fatigability. And so I think there was a question from the last talk, like what about seronegative ocular myasthenia? There are quite a few of those because only that part of the body is affected. So the antibody burden may not be as high, but you see the symptoms right in front of you. So for insurance purposes, sometimes I do this test to help prove that it's there. Okay, so this is just an example of what a repetitive nerve stimulation would look like. So for example, you'll take a muscle that's affected, whether it's like in the legs, in the arms. I try not to do the face, but sometimes I do. You do a train of 10 stimulations and see, does it get tired? And so the normal one, it should stay the same. Your neuromuscular junction is sending a signal every time and it's sending the same intensity. However, in myasthenia, as you see, it starts out really well, but then by stimulation number 4, it's reached a low point and then it starts to recover, but kind of slowly. So this U-shaped curve is a classic myasthenia gravis repetitive nerve stimulation. There's also, I didn't include it here, but the seronegative ocular myasthenia, patients on the call may know of a test called single fiber EMG, which is a much, much more sensitive test that looks for really at a very detailed level, at the level of the single fiber muscle, whether that muscle is fatiguing, and that's if this test is negative. And so what are the treatment options in pediatric myasthenia? Once it is confirmed or even highly suspected, so I may even start it on the first visit, we will start therapy. With ocular myasthenia, oftentimes we can get away with pyridostigmine or methanone alone as a monotherapy. If there are symptoms that break through the methanone or it's just inconvenient, then we could use low-dose prednisone to help with the underlying problem, which is the immune problem. The methanone really is just symptom control, so it's not treating the underlying issue. And I kind of call it it's a Band-Aid, but it's a very effective Band-Aid. And then depending on the severity of a child who has generalized symptoms, I would start with prednisone or prednisolone as a daily medication in combination with mestinon. And it can start really low. I have several pediatric patients really just on like 3 milligrams of prednisone a day or even lower than that. And then in pediatric patients, I try not to get into too high of a dose because these are growing kids and I don't want to affect their bone growth or even like too much weight gain or skin problems, especially in our teenage patients. Adults typically go up to 60 to 70 milligrams daily. My personal maximum for children is 20 milligrams before I start looking for another treatment that may be better for their quality of life. And so when steroid therapy is ineffective or the patient's very severe and did present in crisis, one of the things I think about is actually IVIG. It's very fast. The antibodies are there to decrease the effect of abnormal antibodies, whether they're myasthenia, and if you have another autoimmune condition, it also helps. The starting dose is usually once every 4 weeks, and then we'll adjust based on response. And this could be a chronic treatment option because some patients actually don't mind the infusions. We have several very good home infusion companies that can do it at home in a controlled environment and at a time convenient to the patient. And so when IVIG is ineffective or there are allergic reactions or infusion reactions to IVIG, there are also options for plasma exchange therapy. This can only be done in the hospital because of access to a central line and also all of the things needed for the infusion service. So this is kind of a last resort. There are other outpatient options, but because of the pediatric age range, we're a little limited in them. So for example, mycophenolate and azathioprine, I often don't like starting those in pre-adolescent kids just because about growth, development, long-term side effects. I usually start talking about those in the teenage years. And even then, if they're female, we talk about birth control. And then there are those really new drugs that are really great for controlling myasthenia symptoms really fast. They're only approved for 18 and over. So a lot of the myasthenia patients are asking me about this, and I could try to fight to get them, dosed off label, which I am trying right now. But there is no pediatric indication for these drugs in myasthenia. Interestingly, eculizumab or Soliris has been on the market for a pediatric kidney condition called paroxysmal nocturnal hemoglobinuria. So it is dosed in kids, but for a different indication. And so the prognosis in kids, and this is why I really do like working with children in general, is that they are more likely than the adults to achieve remission or minimally manifesting status where they really don't notice the myasthenia. The other thing is they can start as ocular myasthenia and stay as ocular myasthenia and without any generalization. I have a few patients that are just with their eyes the rest of their lives by the time they graduate at 21 from my clinic. If they are to generalize the ocular patients, I do tell them, let's wait 2 years and see what happens to you. And then I am in the camp, I do recommend early treatment thymectomy if you are a generalized myasthenia patient, no matter what age. So we've done thymectomies in 2-year-olds before, if they're generalized, all the way up to adult age, because they really don't require as many medications to be controlled, or they may need medication for a short amount of time and are on no medications by the time 2 years comes around. And so there are also the other end. I do have some chronic and pretty refractory patients in this pediatric age range. And so it is important to discuss together, like what's best for your quality of life, what can we do in terms of the available treatments for you. The thing about kids who have chronic conditions is that the other thing to watch out for is anxiety and depression and stress about having this condition and trying to be a normal kid is an issue. And so when kids stress out and don't take care of their body in other ways, this can also affect their myasthenia. And then the other thing that I always have to watch out for is there are functional ways that stress affects the body, and we think, is this the myasthenia, or is this you really needing to, like address what you're feeling? So like whole body fatigue, could that be myasthenia? Could it be your stress response? And so the goals of care I have with each of the kids that I see, this is what I ask if really they're saying they're doing okay. I'm like, do you feel normal? Or do you feel more normal than you did before? Can you do what your friends do? And so the other thing that we do in our clinic, we have a team approach to follow up. We have a multidisciplinary clinic that happens for these kids once a year, just kind of as a wraparound care. So we'll have a neurologist on the team, either me or my colleague. We have a nurse care manager that really helps arrange their appointments and lets them know, like, hey, this is coming up, or like be a touch person if there's people they need to contact. Physical and occupational therapy are also part of our team. This is important for teaching kids and their parents energy conservation techniques. Because as you know that 4-year-old, which goes 100% for like an hour and then loses all the energy the rest of the day. So we try to see how we can do that in all ages. A dietitian is important in our clinic because if you maintain a healthy weight, moving that weight is easier and less fatiguing than if you were heavier. Same thing with like if you are having difficulty swallowing, being too thin and not having enough energy is also a problem. And then our social worker helps with the mental health assessments, school accommodations for kids with myasthenia, and then taking care of parents as well as transition into adulthood by the time they graduate to an adult institution. And so another special consideration in this day and age, COVID-19. So I have encouraged all of my myasthenia patients to get the vaccine because getting the COVID-19 infection is so much worse. When you have that combined with myasthenia, it can send you into a very bad crisis, as opposed to the side effects that can occur with the vaccination series. 6 months and older are eligible for the COVID-19 vaccination series. The booster is available to 12 and older for Pfizer and 18 and older for Moderna for bivalent. And so I tell these kids, you don't want to be in the hospital, please get your vaccine. It's still taking a lot of convincing even right now. And then most medications can be continued safely during the pandemic. There was actually a position statement about continuing medications, but maybe being careful about the medications that deplete your immune system a lot unless you need to do it. And so I always tell the parents, like, don't go down the internet rabbit hole. Please go to reputable resources to learn about myasthenia after our visit together. So I always drop the myasthenia.org website so that they can kind of just take the information in at their own pace. We have in our clinic, we got a great shipment of informational brochures so we can physically hand them something and they'll feel like, okay, I can read this, after the visit, after I've digested the information. And so that's all I have. Thank you so much for listening.
Thank you so much. We do have some questions. So with the onset of MG in women being, their younger age, will their children get MG? Like what do they need to know when they're planning a family, the patients who have MG?
Yeah, so that's a good question. So there is something called congenital myasthenia. So this happens in babies that are born to mothers with MG. This is just the mom's antibodies crossing over the placenta and going to the baby. This is a temporary condition though. So that can happen, but as far as getting true like autoimmune myasthenia, I haven't seen that happen. Like as far as my experience goes, it would just be the setup for immune diseases in the family if that's something that's been happening with your relatives.
Got it. Thank you. Do you find that the general pediatricians know about MG so that their patients can get referred to you?
It's kind of hit or miss. Like I feel like the pediatricians at Children's Los Angeles, they know about MG because we all work together. But as far as community pediatricians, it may just depend on the location if they've gotten this education.
Because it is so rare. And do you have any idea what the numbers are for pediatric MG? Like we know regular MG is rare, but when it comes to pediatric MG, is it even more rare?
Yeah, I would say it is. I don't have the particular statistics, but I know, like I read a few papers that do have varying statistics, but it's like one in the several thousands and not in the tens of thousands per, in the population.
And there aren't too many specialists around the country. We know of some, but do you think that's changing, or are they still pretty rare to find a pediatric MG specialist?
Yeah, for sure. It's much more common to find an adult neuromuscular specialist who treats like kids and adults. The pediatric neurologists around here know about MG and can treat it, but as far as like a pediatric neuromuscular myasthenia doctor, it is even more rare. So they do exist. And I think, like with all these new treatments coming up, there will be interest for more doctors to enter this field.
And can you explain the new drugs? I know you talked about it in your talk. The new drugs are not all approved for pediatrics. Do you think that'll change down the line?
Yes, actually. So there are ongoing pediatric trials for these just to prove safety in this population. And so those phase 3 trials are actually ongoing right now. And so I think in the near future, very near future, we'll get an indication, but it may just have to clear the regulatory hurdles.
I see. And the last question that I have is, do pediatric patients who go into remission stay there long term? Or if someone has myasthenia when they're a child, are they always going to have it?
Yeah, that's a great question. So for kids in remission, I still follow them at least, twice a year. There can be a recurrence of symptoms. We tell people with autoimmune conditions, especially myasthenia, if you can help it, don't get sick with something serious. So that means that if the immune system is reactivated in some way, there's a possibility that that myasthenia can come back because there was a setup there before.
I see. I see. Well, thank you very much. This has been very helpful to sort of see another side of it. I think many of our MG patients, this is new to them. So it's been really, really a great talk, and we appreciate it.
Great.
So thank you, Dr. Johnson.
All right. Thank you so much.
We are going to take a break. So we will reconvene here in a half an hour at noon. All right, so everyone take a break, stretch your legs, and we will see you back here. Thank you.
Okay.
We'll be starting again in about a minute. All right. We are going to get started again. Joan, you have to go off mute and Joan will be doing our introductions. There you go.
Okay. I'm ready if you are.
We are ready.
Okay, thank you. Our next speaker is going to discuss living with a chronic disease, something patients and their family can relate to. Stephanie Punt, PhD, has dedicated her career and volunteer efforts to serve individuals with chronic illness. Dr. Punt is a neuropsychology postdoctoral fellow at UCLA, where she is specializing in the assessment and treatment of polytrauma, traumatic brain injury, and recovery. Dr. Punt began her career as a pediatric and adult sarcoma researcher at the University of Washington and Seattle Children's Hospital. Soon after, she was diagnosed with multiple sclerosis. From working with individuals with cancer and her own experience as a patient, she became interested in the mind-body connection and how this connection relates to chronic illness and quality of life. She received her doctorate in clinical psychology from the University of Kansas with an emphasis in health psychology. Dr. Punt is also currently developing programs to bolster resilience, and she works on projects that improve access to telemedicine for school-aged children across the rural Midwest. She also volunteers with Creative Healing for Youth in Pain in Los Angeles and helps with their creative projects geared toward adolescents and young adults with chronic pain. Dr. Punt, will turn the program over to you now.
Hey, thanks so much. I'm glad I get to be here virtually in this space with you all. Let me figure if I can share my screen. All right. So hopefully we all see a giant slide of me and my dog.
Yeah.
All right, perfect. Well, I know the virtual format is kind of awkward, but I'm glad to be here with you all today. Definitely, I always like to be more of a conversation versus me just kind of blabbering on about things. So if there is something that you really want to know, feel free to interrupt. If not, we'll hopefully have lots of time for questions and answers and all that kind of stuff. Yeah, so let's get going. I get to introduce you to kind of a bit about me and my chronic illness journey. But first, because I always, with groups, with anyone, a lot of things the things I'm most used to talking about is actually kind of the mind-body connection, how our thoughts, feelings, behaviors are all kind of connected, and especially stress, right? Stress can manifest as physical symptoms as well. And so I'm a really big believer in this whole mind-body connection stuff. So I'd like to invite you to do a quick progressive muscle relaxation with me, and I'm going to walk you through it. And definitely, if you want to just take this time to kind of zone out, that is okay too. But I always think it's nice to kind of check in with ourselves, take that break when virtual presenting, being in this virtual format, it's hard to pay attention sometimes. So progressive muscle relaxation, here we go. So go ahead and sit in your chair, kind of whatever position is most comfortable for you, and just focus on your breathing. Breathing in, letting your lungs really fill up with air, pausing, and breathing out slowly. And with each deep breath, just notice the feeling of air filling your lungs, and then being released from your lungs. And with each breath, just feel that stress kind of leaving your body. So we'll breathe in together and breathing out. and really just feeling the tension leave your body. So paying attention to your hands, notice how they feel in this moment. Do they feel tight? Do they feel kind of relaxed? And just notice how they feel. And so bring your attention to your hands and squeeze them gently. Hold them tightly and pay attention to that feeling of tension. And with your next exhale, go ahead and release that tension from your hands. Next, direct your attention to your toes or your feet. And go ahead and just hold them tight, noticing that tension, maybe curling your toes. And with the next exhale, breathing that tension away. And next, focus your attention towards your shoulders. And as you're able to, kind of feel them tense up, maybe curl them towards each other. And with the next exhale, just releasing that tension. And with the next inhale, focus on your face. Just notice, are you thinking? Does your face feel tense? And purposely try to tense up your face muscles as much as you can. Just notice how it feels. And with the next exhale, releasing all that tension from your face. And with the next inhale, feel all that air fill your lungs. And feel all the tenseness in all of your limbs kind of disappear as you exhale and release all that tension. And feel free to go ahead and open your eyes and rejoin when you're ready. I know it's a super brief introduction to progressive muscle relaxation, but hopefully this kind of just demystifies a little bit of what the mind-body connection is. And I personally use progressive muscle relaxation a lot, especially right before meetings or presentations, because I get nervous. And the best thing about being in meetings, right, and doing this kind of stuff too, is that it's not really that noticeable. A lot of times you can do super short snippets of this, of just like clenching your fists, right, or curling your toes. Maybe not so much tensing up your face, but there's lots of things, right, that we can kind of do to kind of help ground ourselves when we have other stressors going on. So I am from Washington State originally. I grew up in a small town in this area called the Kitsap Peninsula. It's let's see, I think population when I was growing up in the one town I was in was like around 20 to 30,000. It's definitely grown up since then, but that's where I was born and raised. So I have multiple sclerosis, and Washington State and Pacific Northwest around that 49th parallel has one of the top incidence rates of MS. And why? I remember growing up seeing all the different advertisements on the highway saying like, is it the trees? Is it the mist? Is it the lack of sunlight? And the jury's still out in terms of why, right? I think that's a lot of us can, regardless of our health journey, right? We have different kind of why did this happen? Why did all this stuff kind of set up for the perfect storm of things? And a lot of it has to do with probably with genes and environment interaction stuff. So with MS, they're still trying to figure out kind of what all that means. But grew up in a super close family. Let's see. I was always like the kid who liked doing more outdoorsy stuff, more science stuff. Always thought I was going to be a forester, that kind of stuff. Went to college at the University of Washington. I thought I wanted to be more like biology, maybe go into like medicine. I ended up being in like a health allied medical field, working with different patient populations. But it's amazing to kind of look back and think about the high school version or the college version of yourself and where did you end up? And so um, with college, I got degrees in biochemistry, biology, and actually forestry. Excuse me. So in college, I first started to notice like, oh, weird, my hands and feet kind of tingle every once in a while. Or, wow, I get kind of fatigued more often than I used to. Or, and then towards the end of college, wow, I really had massive headaches. And so I thought that this was all just kind of, and also got reinforced too by different providers, like, oh no, you are, a female with headaches, just kind of, you're stressed, right? Because I was taking a giant course load and stuff like that. I'm also an admitter person here. So a lot of it, right, was just kind of the idea of like, you're stressed, you're somaticizing your stress, and kind of move on and right, continue on with your stuff. So eventually, those kind of really weird, vague symptoms of like, my hands and feet tingle, my face tingles now, the headaches still kind of come and go. I got to the point where I had like daily migraines, which is not fun when you're trying to go to, study things. And then bilateral calf cramps too. And finally found a doctor who listened to kind of what was going on and sent me to go get an MRI. So this is my brain. And this is kind of what a typical kind of MRI brain with MS looks like, right? Multiple sclerosis means many scars. It's for, you probably already know, but just kind of the Cliff Notes version, it's an autoimmune disease. And for some reason, my body decided it'd be a fun time to try to attack itself, specifically the central nervous system. So as you can see, there's these little like ditzels, I like to call them, these little kind of almost like you took an eraser and kind of made a little eraser mark. Those are just scars that my body, showing that my body attacked itself and some kind of inflammatory process. I feel like with any kind of, just from patients I worked with from my own journey too, like it's the process of diagnosis, it's a weird one. It's, I feel like when I got my diagnosis, I felt very relieved. I felt like, oh my gosh, we have a way that we can together kind of operationalize what these symptoms mean, right? Hopefully treat it or manage it. But then at the same time too is, it's kind of a different type of experience in that I had, different employers who, felt that they could not trust me because I had a lesion in my brain, or I had family and friends who actually were concerned that I could somehow give their kids MS, which it's not contagious. Most of these things are not contagious, right? It's just, it's a chronic illness of our body deciding to attack ourselves. There's no risk of, right, spreading it to others, like a COVID or a cold or a flu. So just, it was really kind of disheartening too, at the same time, like you can be happy that you're like, okay, like we have a plan of attack, right? Like we can kind of start going with this. We can work with this diagnosis, to also realizing that like, oh, not everyone is kind of in the same play field. Not everyone kind of understands to the same extent that we might of what this means life-wise, trajectory-wise, all that kind of stuff. So I feel like the diagnostic process, right, is different for every single one of us, but at least with the individuals that I've talked to, there's this common thread, right, where it's like it could be a blessing and also just, really having to take stock and kind of like just other people's reactions to things too. All right, so at the time I was diagnosed, I was 20 years old. So back in 2009, I was, getting ready to graduate from college, get into like a grad school situation, and all I could focus on, right, was this unknown of, well, when is something going to get worse? Even though I had super mild symptoms of like calf cramping or feet tingling, face tingling, headaches, those sorts of things, which all got, controlled after I started disease modifying therapy. It, just definitely the whole idea of like, oh, this is something I have to live with the rest of my life. There's all this uncertainty associated with it, because, there's no, at that time too, when you were diagnosed with something, it wasn't necessarily you didn't know the trajectory of things, if things are going to get worse real fast, or if things were going to kind of stay stagnant for a while. And so also too, if I was, I'm still am, but especially at that point, I was someone who was very active in terms of like like mountain climbing or rock climbing and hiking and skiing and snowboarding and doing all the outdoor things and things that required a lot of physical activity. And so the, the side effects of the disease modifying therapies, like that made me even more fatigued. I felt sick, like you had the flu every other day because of the interferons. And so it wasn't so much like, I don't think I wanted to admit at the time that it was, it did limit the quality of life. Maybe not so much the MS symptoms, but it was more of the side effects of medications, trying to manage some of the symptoms too. So after graduating from college and my symptoms pretty much remitted for, everything was well controlled, became a cancer researcher and worked at University of Washington and Seattle Children's, managed their big file repository, did a lot of quality of life outcome research with individuals and families. And it was really actually working with those different families and patients and realizing like how you could have, we even think of cancer as a chronic illness now. That like how could you have multiple kids, right, or families who have maybe the same prognosis but then have completely different outcomes in terms of functionality or perceived quality of life. So that's actually what got me really interested in the psychology route of things in terms of like how can we help individuals cope with chronic illness, and are there interventions or other things we could do if we're in the healthcare provider field, or even if we're the patient side of things, like are there things that we could do to help set us down a different trajectory in terms of maybe not, maybe we can't control some of the biological stuff, but maybe, are there things that we can control in terms of how we perceive things are going to be. And so I actually got really involved with the Northwest Sarcoma Foundation because a value of mine is helping others. And that was where I was able to kind of really help work with some of the families and help fundraise to help offset patient costs and stuff like that. Kind of with that same idea too, I want to help individuals with different chronic illness and different different life trajectories in general. I also volunteer with Outdoors for All, and they're very focused on helping individuals and families who have intellectual and physical disabilities. And it could be permanent stuff, it could be transient stuff that's more like associated with a chronic illness. And so there's really need to be able to kind of merge, being physically active and things I like with, helping others kind of really be able to like have positive impact towards our quality of life. And so even though I was, in a sense, if you want to think about how I was conceptualize how I was coping with things, right? I was focusing my efforts on helping others and not necessarily focusing on processing what it meant to live with a chronic illness at a young age. So something that I then noticed, right, was like around that time, I started to really get fatigued. And something that with MS is that you have these kind of periods of like just extreme fatigue that no matter how much you sleep, work out, right, just everything just feels super draining and fatigued. And so that was kind of what prompted me to actually, I went and sought help, and it's like, hey, you checking in with yourself? And that was something when I realized like, oh, I wasn't actually checking in with myself or how I was doing. Like I was focusing, so much on everyone else's battery, right, in terms of helping others with chronic illness, volunteering with all these different groups. I did not turn it inward and actually check in with myself in terms of, how full is my battery? I always like to think of it too, like, I mean, we're all like really attached to our cell phones. And I know if you're like me, I'm always like, oh my gosh, we're at 20% charge or less. I better go plug this thing in, right? Because I want to make sure that the phone survives no matter what. But it's interesting to kind of reflect and think about like, well, if we pay that much attention or that much, our phone is that important, what happens if we actually turn that in towards ourselves, right? To make sure that we're fully charged or we're not, gonna just randomly die like our phone does. So that metaphor really stuck with me when someone kind of proposed it that way. I'm like, oh yeah, you're right. So mind-body connections, when I was introduced to this idea, and I really have pursued it kind of career-wise too, which is the idea, which you probably already know, but that there's all these different stress triggers out there, right? It could be external, internal stressors, thinking about memories of stressful events, maybe growing up. And all this stuff is processed by our brain, and we can have these different physiological aspects, like individuals who tend to have more stress, right? With more higher risk for cardiovascular disease, higher risk for different inflammatory processes, higher risk for cancers, all those kinds of things. And so as you think about how important this mind-body connection is, even at its base level, thinking about a headache. So for me, if I'm stressed at work, I tend to, kind of get stuck in a loop of how stressed I feel. I then will clench my jaw, and then I end up with a headache. And so at its base level, that's kind of the mind-body connection, right? I literally amped myself up because I was so stressed about something that I gave myself a headache. So what I work with a lot of individuals is kind of thinking about, like, how can we change how we perceive some of these stressors to try to end up with a different kind of physiological outcome? Maybe stressors are always going to happen, but what are things that we can do to help us be able to handle or take on more stressors before we reach that tipping point where we start having that physiological experience of things? So strategies that I learned, and I feel like I would never ask anyone to try something that I wouldn't do myself. That's kind of my own thing. But so there's different strategies that help kind of improve that mind-body connection, or that awareness that sometimes how we are thinking about things or our kind of emotion side of things can really impact our physiology or biology, and vice versa. And so like practicing gratitude, relaxation, deep breathing, progressive muscle relaxation that we did a super brief version of early on, creative art therapies, prayer, meditation. These are all things that actually have like a research base that's saying that, there's not like one specific one that has the most bang for your buck, but it's more of like, having a menu of options and being able to try out different things that might work for different situations. But kind of taken together, these by purposely trying out these different strategies, you can actually build resilience or build the amount of stress that you can kind of withstand to bounce back from things kind of over time. So I'm just excited. I mean, generally I'm used to, not so much talking about myself, but talking more about this mind-body connection stuff. And so I definitely was excited to kind of help integrate the two, of being able to tell my story and also kind of add in like, oh, these, by the way, like these are like this list of stuff. This has all helped me in terms of, maybe I can't control life, right? Because life happens, life's always going to happen. But knowing that I have a menu of different strategies to turn to and to try out in different situations, like I actually find that really comforting, that, you aren't powerless to all these things. Like you can, like there are ways to, kind of be able to refocus on smaller things that we can control versus getting distracted by all the life stuff that always happens. So we know protective factors against stress. I feel like I was definitely of the mindset of, in terms of exploring the body connection myself and, having a therapist to kind of talk this through with someone and realizing like, oh, like, social support. And with all these things, there's like a research base saying that, that it does have a positive effect on stress. It decreases the amount of perceived stress that you experience. So having like a functional social support system, adopting a healthy lifestyle. And that doesn't mean like going on a marathon every day or eating super clean every day or something like that. It just means like, kind of as you can, right? Doing something that you enjoy, being outside a little bit, if that's a possibility, spending time with others, maybe, drinking another glass of water that day versus not. It doesn't have to be these huge things, but more like smaller micro scale things. Adopting a growth mindset of saying like, okay, I can, or I'll try, rather than it's a nope, no go kind of deal. Celebrating small wins. Like I know for me, if I were to focus on the giant end all be all goals of things, it would be really frustrating, right? Because a lot of times different projects or things take a lot of time to get to the end, right? Or to kind of get to a finish point. So, even like for me, I have tons of sticky notes around me saying like, okay, I need to write a report. And writing a report might be too big of a step, but maybe it's like, put your name on the piece of paper, like that counts. So it's all about kind of celebrating those small wins and setting goals up such that you can kind of build off that positive momentum towards things. And just, kind of being mindful, being aware in the moment. I feel like a lot of times, right, we get distracted with, what's happening on social media. We get distracted by all the things I could have, should have, would have done. But just being able to be in the moment, right? Appreciating each moment, even if the entire day goes not according to plan, being able to reflect in a small way of just like, oh, like there was one, you know, what's one thing that was okay that happened to you today, right? Or something that you're looking forward to. By just kind of shifting our mindset towards that, right, it can really set us up for a lot of successes versus dwelling on the things that didn't go quite right. So at this point in time in my life, I thought, yeah, okay, I've got all these different protective factors in the mix. I'm figuring out all these different strategies. I'm good to go. And then I end up with Bell's palsy. So it's just like one, right? I feel like this is a true example of life, in that you can have all these different things happen, right? And maybe a diagnosis happens and you kind of focus on the one diagnosis, and maybe, right, you found strategies that are helpful for you and you're, quote, doing everything right. And then life throws you another curveball. And yeah, that's just the way life is. So it's all about, right, how do we take these different things and bounce back from it? Like with Bell's palsy, for those of you who don't know, it's this weird inflammatory process that happens with your facial nerves. In terms of why, some people theorize or think that it's, you know, associated with like a viral exposure. Some people, they can have it because of stress. Some people can have like a, you know, like a gland infection. For me, the one thing my doctors could tell me was that, you know what, it's not MS. I'm like, well, that's great. Like, I'm glad it wasn't a flare-up of MS. However, they're like, we don't know why. Could just be because you're just, you know, to be more of an inflammatory person. It's like, cool, guys, cool story. So for about like a month and a half, I couldn't use the left side of my face. It just, my eye was open, like you just can't control it at all, which is just weird. So of course, right, what do you do in that moment? Because we're all human, we start catastrophizing. For me, this was at the start of my clinical psychology program. So I thought, oh my gosh, I'm gonna have to kind of, you know, adjust to a new normal real fast with a people facing job. But, you know, just even though I was learning all these mind body connection strategies, the perfectionistic side of me was really focused on like, how do I perfect them? How do I be the best at them, right? Become the most mindful individual ever, such that, right, as if nothing's going to ever happen again. And so, you know, I really did rely on, you know, kind of going back to the same strategies of like, okay, stress reduction strategies, mind body strategies, you know, deep breathing, you know, scheduling things that I actually enjoy doing for relaxation, right? Checking in with myself in terms of my own battery, where that's at. And, you know, it helped me focus on those and those smaller things that I could control, like when I'm going to schedule something fun or when I'm going to schedule deep breathing or relaxation stuff, even like muscle relaxation, and not focus so much on this unknown of whether or not I was going to regain functionality of the left side of my face. Obviously I did, but it's just weird to think about, right? Like, and to reflect even in that moment, how much unknown stuff there was happening at that time. Oops. So went to Kansas and saw the sunflowers and did my PhD in clinical psychology. So like I said, working with the kind of young adults, adolescent young adults, and adults with sarcoma, a type of connective tissue cancer, that really kind of helped give me like the direction of pursuing like clinical health psychology and working with chronic illness. And yeah, so I, you know, just in terms of what I focused on was just all the different interventions for individuals with chronic illness, how to improve quality of life, reduce, you know, just the anxiety associated with uncertainty. So worked on lots of different projects with that. And I think it's just that helped me, you know, even though I worked with a lot of different patient populations, it really helped me just kind of help, you know, in terms of kind of figure out or process my story, right? And in kind of making meaning out of the trajectory, right? The things that happen to you, and kind of figuring out for yourself, like, oh, this is kind of where I want to be, kind of what I want to do, you know, whether it be volunteer wise or kind of professionally, personally, that kind of stuff. So that led me down the neuropsychology path. So if you think about, like, you know, any kind of chronic illness, it's going to impact how we think, how we feel about things. Whether that come from an organic place or whether it come from just, more of the, the stress associated with managing a chronic illness. And so that's, why I chose to pursue a postdoctoral fellowship, Operation Mend, at UCLA, which is, helping individuals kind of cope with traumatic brain injuries in terms of just because it's really neat because there's tons of cognitive strategies that we can work on with individuals with any kind of chronic illness actually, or in general, to help kind of maximize or make memory more efficient, right? There's things that we can kind of help offload procedurally to really kind of impact quality of life, which I think is really, really cool. So yeah, I still, help individuals in Kansas, working with students and educators to try to work on strategies to help improve, just that growth mindset or how to employ these kinds of mind-body connection strategies in the classroom. I think definitely, with my experience, just by being in that patient role, I think it's really given me a unique perspective in terms of, I'm sure we can all, all of our combined collective experiences together, we could probably write a book on things not to say to someone with a chronic illness. So I really feel like that patient experience early on and, kind of just different challenges that have come up have really helped me kind of revise how I think about chronic illness and how, there's more than one way to cope with stuff. There's all these different, the 20-year-old version of me would have never thought you can have MS and Bell's palsy and all these other things kind of pop up. So I think just, this entire experience has helped me be more flexible in my thinking. I think it's been helpful. And, I think with that too, it's helped me be less perfectionistic in terms of focusing on specific goals, right? And what time these goals are completed. Just as a person, I will always be that person who has a list of goals and checking things off. It's just kind of part of who I am. But focusing on family or helping others, learning, I'm going to be a lifelong learner, that, kind of using those as my guiding compass, that's kind of helped me be more flexible in how I think about chronic illness and how I, just kind of cope day to day with the uncertainty, right, of things happening or not happening in terms of disease process. So yeah, so I know that was a whirlwind tour of me, but I am more than happy to answer any questions that you have. Anything about MS, you're welcome to ask me to. Dating, nothing's off limits.
Well, thank you, Dr. Punt. We appreciate all this information. Just an amazing talk. I really wanted to thank you also for, at the very beginning, doing the muscle relaxation, because obviously, especially for Dova and me, we're trying to make sure everything's coordinated here. So a little bit of stress happening. So thank you for that. We do have a couple of topics to go over. A big one that I hear all the time as an MG patient, how do you recommend dealing with family and friends about your chronic illness? Do you have any things that you do that we could benefit from learning?
Oh man, such a good question. I feel like anytime family and friends kind of come into the mix, it's always interesting. And so I always think, or at least for me in navigating my own family and friends, I feel like, there's friends that no matter what, or family who are going to be 100% supportive no matter what. And then you have people who try to problem solve for you, if that makes any sense. They're like, oh, what about this? What about this? It's like they can't accept the diagnosis. So therefore, it must be all these other things that keep trying to problem solve, which I know I always just, even thinking back to me as a human being talking to friends, or even my partner, how it's I always have a tendency, I think it's just the psychology part of me. I always want to problem solve. And there's some points where problem solving is helpful, I'm sure, right? If you're really truly sitting there as a patient, you're I don't know what to do, right? Let's problem solve it. But sometimes you just have to kind of you just want that acknowledgement, the validation of it sucks right now and that's okay.
Yeah, that makes sense. One thing that I hear with MG is and as you said, people want to solve your problem. They tell you you need to exercise more. Well, that doesn't work with MG. So, you have to come up with a quick response for something like that.
Yeah. Yeah. It's like, well, and then of course too, like what does exercise mean? Like it doesn't mean like you have to go hit the gym for an hour a day kind of stuff, right? It could be like maybe if I have the option, right? If my body, because I feel like with MG, and correct me if I'm wrong, like there's so much like coordination that has to happen in terms of like your body's got, to exercise. You got to be in a position where you can exercise and kind of like at your own body's pace. It's not going to be like this, go hit the gym for hours. And kind of similarly with MS, like, you're told like, oh, if you maintain a healthy weight, if you're active, right, that these are all things that help decrease fatigue and help improve symptoms. And so for me, like exercise has been helpful in terms of like decreasing my headaches just in general. And I think it's actually, in terms of like symptom progression and stuff like that, it's actually been very, very helpful for me. But I also know that, there's days where I don't want to exercise. And so so it's all about for me, it's been scaling back what that means. And with friends and family who are just like, we have to go do this, we have to exercise right now. It's more of, like for me kind of saying like, oh, well, me walking from bed to kitchen, that counts. Like those kind of like smaller goals to kind of scale back the goals and focus on something that you can do. Maybe it's gonna be chopping vegetables. That counts as something, right? Versus being sedentary and not doing something. So I always try to like, with friends and family, I feel like kind of acknowledge like, yeah, exercise is important, right? Because we all know regardless of disease status, right? Exercise is important as a human. Yes. But like, and there's other ways too, to kind of focus on maybe scaling back the goals. It's more manageable, or not every day has to be an exercise day.
Yeah, that's important. Thank you. So what would you suggest if you feel like you're running out of steam? How do you not get frustrated with yourself?
I think when I notice it for me, I definitely I acknowledge it. I think in the past I got into trouble kind of with myself, right? In my thinking, in that I didn't want to admit it because I saw myself as like, it's like, you're a young, healthy individual, right? Like, why do you need breaks? Why do you have to do this kind of stuff? And, the sooner I can, like, I've actually gotten a lot better with it over the past like 10-ish years, where I can kind of go, okay, self, like you're running out of steam. You're not thinking straight. Like you're cognitively depleted right now. So let's make a note of where you're at and then restart tomorrow. So it's been a lot more like scheduling in breaks, and also being able to, the quicker I can acknowledge like, hey, I'm mentally not checked in right now, and then make a note of like where I am on a task. Actually, like when I come back to it, I can complete it a lot more efficiently and not feel lost, right, in some of the content, because when you get really cognitively tired, you can't really, I feel like half the battle is I'm trying to figure out like, where'd you stop? So that's been my kind of tactic, be able to acknowledge and then kind of problem solve, taking breaks.
Oh, thank you. That's excellent. Here's another question for you. As a support group leader, I hear a lot about, and I'm guilty of this too, we feel we're having a good day, a good week maybe, so we kind of get into denial. Well, I don't really have it that bad. It's really okay. How did you find a way to actually just accept this and not have it frustrate you?
Well, I think it's something that for me, it's always going to, maybe for some of us, it's always going to be in the back of our mind, right? And it could be a frustration point. I know early on, that was something I did a lot, was just like comparison of like, even being in the MS clinic. I felt that like I couldn't relate to the other people because they had worse physical symptoms than I did. And, in terms of like days where stuff wasn't that bad for me, it was, definitely, you start kind of convincing yourself like, oh, it's not that bad. Like, of course you could go finish all these chores, or you could go do these things, right? But then I think also just kind of, as I learned too about me, like, hey, if I actually, on a day that's a really good day, if I start doing everything, like all the different tasks, I get tired, and the next day I have to spend recovering from that day. So kind of just being able to be like, I know it's for, it's like, Stephanie, on the one hand, it's very frustrating that you can't do everything today, but isn't it nice you have a good day? And so let's try to keep extending it So like that self-talk of like, we can be frustrated together self, and we're going to pace ourselves.
Thank you. That helps a lot. Well, I think connecting the whole psychological point with the body, as you said, that's really helped a lot of us, I'm sure, with MG as well as MS. So thank you for that. I think we're running out of time here. Dova, do you have anything else to add?
I just wanted to ask, we have support groups, we have support groups all over the country, and we had like a positive side to COVID was that we were able to continue our support groups on Zoom, and we actually were able to have people attend that couldn't necessarily attend in person. So it was kind of a silver lining, you would say, for COVID and our support group attendance, because someone that maybe couldn't drive to a support group still had the energy to do it online. So we really had a very good experience, with having more people attend, and more people attend in places that they couldn't get to one in person. So we're definitely keeping that. We will always use Zoom, a combination of Zoom and in person, for our support groups. But I wonder if you could talk about how support groups and being with other people with your disease helps you cope.
Yeah, I think it's a great question. With for me, like honestly, at the beginning, I felt really shy about support groups, because I felt like I wasn't sure if I would, like I feel like being a socially anxious person, like I feel like there's always the idea of like, are you going to be judged? Are you, kind of MSC enough for the group, right? That kind of stuff. If you didn't have like active symptoms at that time. And so for me, I was kind of apprehensive. But then after joining more support groups, I even like helped to develop an intervention in Kansas, Missouri for individuals with MS to help them like lose weight too. It's just really neat to be able to work with other people, like other colleagues too, who had MS and diagnosed maybe later in life or even around the same age as me. And it's just really neat to, it was like this unspoken truth, and you don't have to necessarily start off with the whole like, hey, I'm Stephanie, I have MS. Like, okay, like what does that mean, right? And start kind of from scratch. It was just like this really neat understood background of like, I have a mess. Okay. Like, and then we could actually kind of focus on more day-to-day stuff, right? Or like, more of like friendship kind of oriented things, versus having to feel like you have to explain what MS is, what it means. I mean, for a lot of us too, right? These things are unpredictable and can be invisible. It's not like we broke an arm necessarily. So everyone's like, oh, you have a cast, therefore you broke your arm, right? This is an understood societal understanding of kind of what's going on. So I think support groups have been neat just in terms of, it's not as tiring to make friends and stuff like that, because it's like, you can learn neat things from each other in terms of like coping and stuff, or maybe like things that you can't necessarily ask friends and family about.
Yeah, I agree. Yeah, go ahead, Joan.
It comes up so often in meetings, and just sharing with people that can relate. I mean, if you don't have MG or MS, if you don't have the disease, it's hard to really explain it to someone. And when you're in a group of like people that have the same thing, they understand, and that's a comfort.
Yeah.
And we do have many people report from the support groups that, they had never met anyone else with MG. So to go to a group and have 10 people there with MG, is really something else, because they never met anyone with MG. Since it's rare, you don't just run into them every day. So it's been a great thing. We've also been able to do different things with the Zoom support groups. So for instance, I see Leah's on the call today. We have a Spanish speaking group. And so we do it on Zoom because then people from all over can come. We have a caregivers group. We have a young adults group. And so then we get people from all over the country going to different kinds of support groups. So I think I don't think we have any other questions, Stephanie. I really, really appreciate you coming on. It was great to hear your story, and I hear you're going to send me a PDF of that we can use in our resources page. So that will be
Yep.
awesome.
Thank you
Yeah,
so
All right.
and that
much,
was really
Stephanie.
Jay.
Thank
you
you.
very
welcome.
much
Thanks so
for
much
your
for having me.
time.
Enjoy the rest of your weekend.
Thank you. I'll see you later.
Bye-bye.
Bye.
So we now have actually a recorded video of, oh, are you doing this or am I doing this?
You're doing it.
Okay, so we have a recorded video from, Joan and I interviewed the fire chief, and he'll introduce himself in the video, from Gilbert, Arizona, where Joan lives. And I'm going to share my screen and share this video. Just give me a second because it takes me a moment to get it up, and we will play it for you. It's not too long, and then we'll talk about it after.
First, thank you, Mike, for agreeing to talk with us. We appreciate your time and your ever-changing schedule. Would you please introduce yourself to us and tell us about your role at the fire department?
Hello, everyone, and thank you, Joan, for that introduction there. My name is Michael Riley. I'm the Deputy Chief of EMS. That's EMS stands for Emergency Medical Services. As many of you may be aware, the fire department provides emergency or medical services for 911 citizens. And it's pretty predominantly, that's majority of our calls. I think the last time we did data on it or pulled data on it, it was about 75 to 80% of our calls are medical in nature. And my responsibility is pretty much all the medical training, the medical accreditation, the compliance, the regulations, anything our crews do medically falls under my division. I've been on with the fire department for a little over about 18 and a half years. So that tells you a little bit about myself and what I do in my role as Deputy Chief of EMS for the Gilbert Fire and Rescue Department.
Well, I know all the residents of Gilbert sure appreciate having you on. My first question would be, what will EMS be looking for when they arrive at a patient's location? In other words, how will you assess us?
So I thank you for asking that question. So it obviously depends on the nature of the call, why we're called out there that day. But if we have we'll refer to it as a sick patient and somebody that and I hope I don't murder it here, myasthenia gravis, and we have a patient that, you know, is experiencing an episode, first thing we're going to do is to make sure that they're able to respond to our commands. So we're going to check what we refer to as A&O times 4 questions. We'll be asking those. Can the patient can the patient answer who they are, where they're located, the time of day it is, and who the President of the United States is? Those are some of the questions that we may ask a patient. Other things that we'll be doing assessing are vital signs, blood pressure, pulse, how many respirations they have. We may hook them up on a cardiac monitor and read their EKG. But we're not only assessing the mentation of the patient, but we're also assessing the vital signs. So those are some things on the immediate assessment that we're going to do.
Okay, thank you for that. So for example, with myasthenia gravis, if our diaphragm is weak and we can't take in a breath, we can't go, that means we're in trouble. And if you give us oxygen here, we won't be able to take it in. What is there that how can we tell you that? Okay, go ahead.
Yeah, I'm sorry, Joan, to interrupt you there. But, I think it's important that if you don't have, let's call it a caretaker, a family member there, we need some type of identification of the disease process that you have. And so I think I've shared with you, Joan, a form that we pass out to some of our patients that may be living in a senior facility that details totally who you are, your name, along with your medical conditions, along with your medications that you're on. If you have that in some place, either where you can hand it to us or on a refrigerator or someplace close where we can able to use it, That's very important for us because then that's obviously going to affect the treatment and the assessment that we are, doing on you as a patient.
Absolutely. Do you routinely check things like I've got a little medical alert bracelet here? Is that something that is routinely checked? Because I've heard some people say they don't think they check it.
No, for sure. Our medics and our EMTs on the fire truck, and along with our medic and EMT on our ambulance, they should be checking that. That's part of that assessment. One of the things that we do, obviously, is a detailed assessment. We talked about our primary assessment. When we come up and we get those vital signs and we check your mentation, we're probably also going to do it. We should be doing a detailed assessment, and that's a head to toe assessment to make sure that, you don't have any deformities, abrasions, cuts, anything along the lines of that. And that's where hopefully that bracelet will be identified by one of our members, and they'll be able to say, hey, you know what? This patient here has myasthenia gravis. So
I have a question, because it's a rare disease and because there's so many rare diseases, you can't possibly, the fire department and all the people that come to respond can't possibly know all of those diseases. So when you check the medical alert bracelet, what do they do when they check it? What does that involve?
That's a very good question. So Dova, if we are not familiar with the disease process, we have an iPad there. It has internet connection. We can basically look up that disease process and identify, hey, what are some signs and symptoms that are associated with myasthenia gravis? We also have the opportunity to call a hospital, and we have a base hospital, which in Gilbert is Mercy Gilbert. And we have the opportunity to talk to a doctor saying, hey, this is the condition of the patient. This is what they're experiencing. This is their disease process that they have. Can you tell us exactly what's going on here? So we have tools or resources that we can use to inform us of or educate us on, disease processes that are not very common.
Thank you, Mike. The MGFA has an actual several pages that we've been asking people to print out, and it tells information that should be given to EMS if they show up on what to do when we can't talk, for example. Is that something that would be helpful to you?
Yeah, I think in the fire service and as first responders, there's no such thing as, too much information. So, pamphlets like that, sheets of paper like that, all that information is going to be super, super beneficial to us, to say the least.
And also, since most of us are under the care of a neurologist, which, there might or might not be at Gilbert Hospital, for example, that probably would be a good idea to have somewhere handy the phone number for our neurologist.
Yeah, 100%. All that medical information, Joan, if you remember that form that I sent to you, if that form, along with any other medical information that you believe is going to be pertinent to your care, if that can be kept in a folder or kept in a location in your house where either you can point to it, the caretaker can grab it, or unfortunately, if you're not able to talk to us, where we can see it and say, hey, you know what? I recognize that form. I recognize this packet. Let me take this with us.
And we would love, the MGFA would love to be able to post a form like that on the website. We could use it, we can use it for everyone. It doesn't have to just be the local fire department. That would be great for all of our patients. The other thing I was going to ask, I think Joan has this on her questions, but while we're talking about it, we do have a wallet card that we have people fill out to keep in their wallet that has their neurologist, their symptoms, their medications. At what point in the process when someone calls 911 would a paramedic look for someone's wallet?
We're probably not going to go through your belongings, to be honest with you. There's a chance that we will, but I can't guarantee it over that's going to happen on every single call. So it's important that, those type of belongings that is going to affect your treatment is in a position where we're going to be able to easily grab it or retrieve it for you, or you hand us your wallet and, point to that card. We're not going to go through somebody's purse. We're not going to go through somebody's wallet. That's not what we do in the fire service. So
Well, that's a good tip to let people know. And maybe Dova, at some point, that'd be something we can put on the website, because everybody's got a wallet card. Well, most people that have this, but like Mike just said, if they can't get to it, at least maybe keep one in your wallet and maybe keep one tacked up on the refrigerator or something.
Right, and we do recommend people have one, like have their caregiver have one as well in their wallet, so they can get to it quickly and give it to whoever, any medical professional, either paramedic or in the emergency room. So because then that has the list of medications, which is very important.
Yeah. One other thing, Mike, I've heard that it's a good idea to actually visit your local fire department to let them know that someone in their area has myasthenia gravis. Is that something you would welcome? And I know you're speaking only for Gilbert, Arizona, because we have people from, we could even be having international people tune in today. But how do you feel about someone coming in and actually talking to you? Is that helpful, or with so many diseases out there, is that just confusing?
Yeah, especially just depending on where you're at with the disease process. So if you, let me just put it this way. Yes, I would highly encourage you going to your fire station that is that you believe is closest to your residence, and letting them know of your situation. Let me just put it that way. So.
Oh, that's helpful, because I think because it's so rare, there's only, I don't know if you know this, Mike, there's only 60,000 people in the US that have it. So the odds of you getting that call are, probably pretty remote. So I think if we can all let our local EMS know, whatever state you're in, whatever country you're in, at least if you do get a call, that's a way we could help you, right?
Yeah, no, for sure, for sure. So we would highly encourage you stopping by the fire station, making sure that you give them your address, and making sure that, maybe you can put a face to a name, or a name to the, unfortunately, the disease process, so that if that crew responds, they're familiar with who you are.
Oh, that's so helpful, Mike. Thank you.
Mhm.
Dova, do you have anything else to add?
I guess our what I'm hearing is, if you feel like you're not doing well and you feel like you may have a crisis, be sure your information is somewhere where it can be seen. So put another wallet card on the refrigerator. And I think the scariest thing for the patients is when they can't speak. And it's great if they have a caregiver or they have someone there with them. But the scary thing is for them is when they don't. And then they can't speak because their diaphragm isn't working. They can't get the words out. So that is great to know, to be sure in those situations, or even at all times, to have things very easily accessible for the 911 responders. So I think that's fantastic. And if there's anything else, Mike, that you can think of, we think this is very valuable for all of our patients.
Yeah, the only thing that I can think of, is maybe to have a paper and pen handy. With our members that we've responded to that may be deaf, I know a lot of times they may have a paper and pen handy. I don't know if that would be the same case for patients that are encountering this disease process, especially if they can't speak. But having that other communication tool in place or nearby so that we can communicate with them would definitely be very beneficial. So not only all the medical information, but also a utensil, whether it be a phone that you can communicate with, whether it be a piece of paper, an iPad, any type of device out there, would be helpful. So obviously what hinders us is not getting information. So anything that would assist us in that communication process outside of verbal communication would benefit us as your primary, medical assistance or medical needs. So.
Oh, that's excellent, because, the odds are 50-50, you're going to have someone at home with you. And then again, maybe not. Or let's say you're, at the grocery store, you're at a game or something, and you're by yourself. So at least if you have the opportunity to give information to the EMS, then you have a better chance of getting help.
Yeah. Yes,
Yeah,
for sure.
We appreciate this so much. It will be very helpful. We usually hear it from the patient side, and we're really happy to have you here to to explain things to us from the other side of the coin. So
Yeah,
it's been very helpful. We really appreciate your time.
no, and thank you, ladies, for getting the word out there, getting the education out. We greatly appreciate it. There's nothing quite like going on a call going, okay, what is this? So if the more information that we get out, not only for the patients, but also the providers, which obviously would be us, would help us all out to the nth degree. So thank you so much for allowing me to be a part of it and provide this information and education.
And just know, Joan's going to come with a lot of brochures about myasthenia gravis for you all. She's going to give you lots of information, so you guys will all know what it is.
No,
Right.
we welcome it, to say the least. So
Okay. Well, thank you, Mike. We appreciate everything.
thank you.
All right. Have a great day.
You too.
Bye.
Okay, everyone. I hope everybody could hear that and see it. Jane told me yes, it was, you could see it and you could hear it. So we hope that was helpful. We're going to open up everything at the end. We have one other short presentation that we're going to provide. So I'm going to share my screen, and Joan is going to talk about how to beat heat and stay cool. Let me get this into presentation mode. All right, Joan.
So one of the things in the Southwest, especially Arizona, where I'm at, we need to talk about ways to stay cool and beat the heat. And the St. Petersburg, Florida MG group came up with this presentation and told us we could present it today. So here we are.
I'm trying, hold on.
So why do we need to stay cool? Well, with MG, temperature extremes of either hot or cold can cause our muscles to weaken. Extreme hot temperatures, humidity, sunlight, they're all bad for us. It's also good to remember it's not just outdoor temperatures, but indoors, hot showers, baths, saunas, hot tubs, even hot drinks and hot food can aggravate the symptoms. And swimming pools, that's another tricky one. If you're working out, if you're even walking in your pool, the water in the Southwest can get really warm. You are working up a sweat, but you're not able to actually cool down because you're in warm water. So just be aware of that and take it easy, take it slow. And if there's any question at all about how you're feeling, get out immediately. The St. Petersburg group came up with some items to help us cool, and they suggested cooling vests and towels, wearable neck fans, cooling shirts, cooling umbrellas, which I had never even heard of. We'll show you a picture of that in a minute. And then battery supply backup for power failures. And then there's one other thing that I don't know if it's in here, Dova, freezable seat covers. You can buy them for little kids to put in their car seat. They're called bum coolers. And it's a pack that you put little packages that you put in the freezer into this pack, and you put it on your car seat. And it really does work. So that's just another tip. So here are some of the cooling vests that the group had suggested. And these you wet and freeze, wet and refrigerate. And as I was talking about, you insert ice packs. And there are some that you can do in the vest scenario, but you can also do them and put them on the car seat. And those are really amazing. When you go into a store and come out, in 15 minutes, your car can be 150 degrees. So those are good options for us. Cooling towels are really popular with MG patients. So easy to wear and easy to use. Wet them, put them around your neck. If you are really going to be out in the heat for a while, refrigerate them to keep them cool extra long. Lots of styles, colors, and prices to choose from. The cooling fans, those are pretty neat things. They're lightweight and they sit comfortably around your neck. And again, various price ranges and styles to choose from. Cooling shirts, now that's a really good tip. They do have SPF sun protection in them. And what's really nice is they're moisture wicking. So they take the moisture out and keep you dry, which keeps you cool. And again, styles, colors, prices, Amazon's got it all. And here are the cooling umbrellas. I had never heard of these. I think they're really incredible, especially if you're going to be sitting outside at a baseball game, for example. It blocks the sun, allows you to be outside a little longer without getting too hot. And some even have fans or misters built inside. Again, you can Google and find hundreds to choose from. This is a really good tip. Those of you that have BiPAP or CPAP machines, in the summer, especially in the Southwest, power can go out. And if you're dependent on a machine, it's always good to have a battery backup. Oh, Dova, you may want to talk about this.
Guess I should unmute. So we have a new MG online community that we have now up and running. It's a very cool place to go to chat with others, share resources, and learn more about MG. We're adding to the online community every day, new resources, new things. We have a library, we have a wellness center. It's very, very cool. You should go check it out. I highly recommend it. So that is one of our new, it's a new feature that we have. I think that's the end of this. Okay, I'm going to stop sharing this, and I'm going to pull up one more thing. So if anyone would like to come, wait, am I sharing? Do you see this? Yeah. If anyone would like to come off of mute and and talk, you're welcome to do so. These, Joan, do you want to go over these support groups?
Yeah, sure. So in Arizona, we do have a couple of notifications for the East Valley. Kim Vigil and myself take care of the East Valley, which is, kind of south and east of Phoenix. And then in the West Valley, we have Johanna Milford. And I think, Johanna, you're on today. So good to see you. In Tucson, Gene Casagrande has been running the group there, and I assist him at times. And then in California, we have Connie DePasqua. She's out of Palm Springs, I believe. And the last person on our list is Evan Green. And we've got an email there for Evan.
Yep, thank you, Joan. I also wanted to mention that the National Patient Meeting will be held next year, March 26th to the 28th in New Orleans. It is going to be in person. We hope that people will join. We will have virtual options as well, because we know that it's difficult to get there for some people. Before we chat, I'm gonna, everyone can come off of mute in a second. I just wanted to go over one more time and thank our sponsors, Alexion, Argenix, Janssen, UCB, Immunovant, Horizon, and Sanofi. So I'm going to stop sharing. And if anyone would like to come off of mute, if anyone would like to say anything, you are welcome. Nobody? Okay, everybody. Well, we appreciate your attendance. We hope that you found the information helpful. And the recording will be posted in a few days on the website. So thank you everyone for joining. We always appreciate you coming and watching our regional conferences. And thank you, Joan. You did an amazing job.
Thank you, everyone. Have a great rest of the weekend.
Thank you.
Thank you.